Thank you so much to the organizers for including me in this. And I just want to thank one of our chief residents, Greg Kazarian, who's here, who did an amazing job putting this paper together for the special issue and also putting all of these slides together. Thank you, Greg. So I'm going to talk about everything other than fractures, and this is going to be a return to play following injuries to the cervical spine. And as background, I think as most of us would agree, contact sports probably make up the most common cause of cervical spine injuries outside of the fractures that we've talked about up to this point. And generally speaking, trying to figure out how to get people back in a safe and timely fashion is challenging. If we think about it sort of globally, the three things that you really want to think about that can make you comfortable in terms of getting people back to play is, are they asymptomatic from their injury? If they had any neurological dysfunction, has that returned to normal? And do they have painless range of motion of the cervical spine? If those three things fit, then for the most part, getting people back into their activities in sport is very reasonable. However, I think it's very important to understand that there's significant variability. So if we think about where does that variability come from, there is a variability in the injury type and severity. So not all injuries are made the same. And then there's individual specific risk, and we'll get into the details of both of these things. So in terms of the injury type and severity, these are sort of some of the common conditions. And again, I'm not going to talk about fractures because that's been talked about, but you can sort of divide these injuries into sprains, strains, and contusions, burners and stingers, cervical cord neuropraxia and transient quadriplegia, and then spear-tackler spine. And these are significantly different injury patterns that suggest a completely different severity. So understanding the injury type is critical. And then in terms of the individual specific risk, if there's history of prior injury, how long have the symptoms been there, are there any anatomic or congenital variations, and then what is the sport that they're looking to return to is going to have a significant impact on the treatment recommendation. And that's what makes sort of this decision-making around return to play so challenging. In general, I would say, break down your return to play recommendation into injury-specific, patient-specific recommendations with that thought of what we talked about earlier in terms of range of motion, neurological recovery, and no neck pain. In terms of the specific considerations, again, I'm going to talk about each one of these first four because we've heard a lot already about number 5. So let's start with sprains, strains, and contusions. I think in general, if there's a more severe injury, which often happens with these ligamentous issues, such as a fracture or neurological deficit, that's what's going to impact the return to play recommendation. But if you do have a patient who has specifically an isolated soft tissue injury without any neurological deficit, this is probably the one that really follows that initial rule that we talked about. In general, I think that x-rays are always going to be necessary. You're going to want to get x-rays. You're going to want to make sure that the cervical spine is stable. But once the symptoms have subsided, which could be a couple of weeks all the way up to a month to 6 weeks, and there's no instability, these are generally patients that we could feel comfortable getting to return to play. Burners and stingers have some variability in them. In general, when we think about burners and stingers, separating burners and stingers from a cervical disc herniation or transient quadriparesis is extremely important. The management of burners and stingers is going to be really highly dependent on how many episodes there have been in the past. In general, at least for my practice, a first or second time event, which is of short duration, okay to immediately return to play. Anything that lasts more than 24 hours, that's somebody that we're going to want to get imaging on, including advanced imaging like an MRI. And then if there's a third event, then you sort of want to think about exactly what's going on. It's not an absolute contraindication, but maybe a relative contraindication to keeping somebody out of play for a little bit. Cervical cord neuropraxia and transient quadriplegia, I think, are the most important things that you don't want to miss when you're thinking about return to play. These are acute, transient neurologic injuries to the cervical spinal cord and often can cause sort of this burning and pain, which can, sometimes be thought of as a burner or stinger. But these are patients, especially if they have repeated events and deficits that last for more than 36 hours, this could be somebody that would be an absolute contraindication to return to play. And I'll talk a little bit more about a consensus that our society put together around return to play in these patients in particular. Spiritacular spine, just quickly touch on this. Spiritacular spine is a very specific set of things, which is you've got canal stenosis, you've got a straight cervical spine, and you've got radiographic evidence of some minor trauma, and somebody who's involved in a sport where they are doing activities that are going to involve head-first contact. In general, for me, this is an absolute contraindication to return to play because there is a significant risk of cervical cord injury with collisions. There are multiple other factors that influence return to play recommendations, including congenital and anatomic variants, issues at upper cervical levels, a lot of things that, I'm already out of time, so we're not going to get into. But in general, if you have an opportunity to look at this paper, I think, we try to go through them as best as possible. I just want to, quickly end with two slides. The CSRS consensus recommendation around transient quadriparesis and cervical cord neuropraxia. This was a study led by Greg Schroeder, and they did a really nice job. And this was with patients with prior transient quadriparesis events who are now asymptomatic. There was a strong consensus to let people return to play based on their canal diameter, and specifically a canal diameter greater than 10, unrestricted return to play. Canal diameter of less than 10 was a relative contraindication. If you had transient quadriparesis, were asymptomatic, had T2 cord signal changes that were resolved, then if you had a canal diameter of greater than 13, return to play was okay. Less than 10, again, in this patient, absolute contraindication. And anything where there was continued T2 signal change was considered an absolute contraindication. In terms of operative recommendations, I think I'll just skip the slide. We can talk about it in the time we have, and I'll stop there. But thank you again. Hopefully we got everything covered.